Good evening, everyone, and a warm welcome to our Pan India ILD multidisciplinary meeting. We are joined today by our regular panel of stalwarts Rajan Sir, Prahlad Prabhu Desai, Murli Mohan, Dr. Mithun as a rheumatologist, and Dr. Aparna from CMC Vellore as a radiologist, and Dr. Sharda as a pathologist. We have got Professor Athol Wells, and we are hoping Dr. Sonia also may join us depending on their schedules. They
She
might
has
leave.
joined. She has joined.
Yeah. Hi, Sonia. Good to see you. And their insights always enrich our discussions. We have six interesting cases, one each from Prabhu Desai, Dr. Elizabeth, who is from Kochi, Esther, and Dr. Rajan sir. And there are three cases from my side. And as always, we focus on collaborative discussion. Let us start with the first case. I'll share my screens, and Prabhu Desai sir's case will be discussed first. Yes, sir. I hope you can see my slides. Yeah. Somebody is talking, we can't hear. No, is it I am not able to hear or everybody is not able to hear?
Prahlad's audio is bad.
My audio is bad.
Now it's better. Now we can hear you.
Can you hear me now?
Yeah, go ahead, Asmita.
Okay. So this is 53-year-old female homemaker, resident of Mumbai, tuition teacher, okay, and non-smoker. Biomass exposure presented for the first time in March 24 with complaints of with some biomass exposure, complaints of progressive breathlessness for 6 to 8 months, and dry cough. Since childhood, she used to get seasonal cough. Okay. History of pigeon exposure is plus. Family history of lung cancer in father. No past history of TB or COVID in the past. Her vitals were fairly okay. Her saturation was 87 on the room air when we saw her. And there were bilateral crackles. The heart sounds were P2 was loud. There was a clubbing. Cyanosis was there when we saw. And it was you can go ahead. Then saturation was later on 91% on 2 liter, desaturates to 80% sometime despite of O2 without minimal exertion, bilateral edema fit, and she was taking some Ayurvedic treatment, limited activity tolerance, and she was later on oxygen therapy. She was put on mycophenolate, nintedanib, prednisolone, and lacilactone on oxygen therapy. Somebody also added tadalafil, and in view of severe pulmonary hypertension on echo. So this is her ANA 1:320, ANA blot, dsDNA, ANCA-C negative, myositis profile was pending, which was negative. Polycythemia secondary to hypoxia, probably we thought hemoglobin was 15 grams, and HP panel was strongly positive. Cardiac workup, Dr. Budkure, are you there?
Yeah, I'm there.
Can you just talk about her? We referred for him for a 2D echo, and in view of the severe pulmonary hypertension, we thought of doing even saline agitated echo.
Yeah. Am I audible? Yeah.
Yes, sir.
Yes.
Yeah, I'm audible. So actually, the pH has behaved very abnormally. The echo before she came to us in 2024, the echo was recorded to have a pH pressures of 88. I think then after I think the treatment was started, and then we had seen her somewhere in April. By that time, actually, the RV function had recovered. There was hardly any TR to get the exact PA pressures. But then we did this saline bubble contrast, and in that we found a lot of bubbles coming into the left atrium and left ventricle. Now, these saline bubbles are quite actually, you do it just by hand agitated saline mixed with the blood. generally the size of these bubbles is such that it will not cross the pulmonary capillaries. And if it takes at least 4 to 5 bits to come to the left side, then we suggest that it is coming from the AV malformation and it's not coming through the PFO, because from the PFO generally they would come within the first 2 bits. So it took at least 5 bits for it to reach the left atria. And not only that, afterwards we had done a transesophageal echo where also the PFO was ruled out and we could see those bubbles coming through the pulmonary veins. So that gave us an indication that probably she had some pulmonary AV communication. And quickly, I will tell you that by that time the RV function had actually normalized and the TR was not discernible. But later on, as we saw her in this year, the RARV had significantly redilated and the PA pressure had again gone quite high. Yeah, please carry on.
Uh, lung function and images. Okay, so this is a lung function report. You can see that forced vital capacity was significantly reduced, and 50% of the predicted DLCO was extremely low, 16-17% of the, and DLCO SB by VA, that is KCO was around 42% of the predicted. Patient had RVTLC increased. Okay, and these are the two lung functions 3 months apart. Okay, 1 year and 3 months apart. So these are the 6 minutes walk test, significant drop. Okay, and chest CT discussion.
Yeah, Aparna.
Yeah, just sharing my screen. So we have two CTs, one from April 2024 and one from 2025. So the April 2024, I'm just showing first. So the pulmonary artery is dilated, consistent with the pulmonary hypertension. Not much of RARV dilatation, maybe mild dilatation is there in 2024 at the time of the CT. So after Sir told about AVMs, I looked for any AVMs. I could not see any large AVMs. Sometimes they could be very tiny peripheral ones, but nothing gross that we are seeing on the CT. Coming to the lungs, what we're seeing is there is some kind of diffuse ground glass opacity throughout both lungs. And we are seeing multiple tiny cysts which are scattered throughout both lungs. Which are probably slightly more in the upper lobes. Upper lobes, there's a little bit of scarring and pleuroparenchymal thickening also. But rest of the lungs are showing all these tiny cysts, numerous and diffuse ground glass opacity. In the lower lobes, there are some lobular kind of areas of sparing or probably air trapping are also there in the lower lobes. One more thing, because of the tiny shunts, I was looking for any features of chronic liver
Liver,
disease.
yeah.
Yeah. So liver, not grossly looking very like a cirrhotic on the CT, but maybe we can look for that also. And no gross portosystemic shunts also. That is another thing I looked for. The whole abdomen has been covered in the CT. So that also I could not see because that can also sometimes cause this bubbles, I think. So that also I could not see anything. So next CT is 2025, which is almost similar. The lung findings are almost similar, but the pulmonary artery has probably increased in size. At this time, we have some expiratory CT also, which does show that some of these areas are looking like focal areas of air trapping are also there. But otherwise, rest of it is the similar thing with numerous tiny cysts. So what all can we consider is one is because this biomass exposure is there, whether these are like tiny emphysematous things. Second thing is whether this could be like an LIP because there is background ground glass also and numerous tiny cysts, but they're very fine cysts than what we usually see, I guess. Hypersensitivity also can cause this, but and this few areas of air trapping that we are seeing could kind of favor hypersensitivity, but there's not much of fibrosis and we are not seeing centrilobular nodules. So other typical findings are not there for hypersensitivity. And this pulmonary hypertension definitely looks out of proportion to this lung findings also is what I thought. Yeah, these are my thoughts.
Now, if you stop sharing, I'll share the
Yeah.
questions.
What are the questions, Prahlad?
Yeah, I'll just share.
Let's come to the question.
Yeah, these are the questions.
So now this patient is on MMF, nintedanib, and should we continue this line of therapy or not? That's number one. And regarding pulmonary vasodilators, okay, should we reintroduce? Okay, that's a second doubt. And what exactly we are dealing, whether it's an hypersensitive pneumonia because there is at least she's sensitized to most of the fungi, and so of course the role of transplant in this also we want to discuss if there is no role of any medications actually.
Why did you classify it as CTD-ILD, Prahlad? What was in favor?
No, actually, not CTD-ILD. Actually, we were initially the ANA was 1:320. That's why we was thinking whether it's some possibility. That's all. And pulmonary hypertension. That's other important reason. I mean, so it was not fitting into really speaking any particular. But
Yeah.
considering the amount of breathlessness and cyanosis she had, and pulmonary hypertension she had. So we could not label her as a primary pulmonary hypertension also because of the lung lesions.
You don't have a right heart cath on her, right?
That Dr. Burkule would like to comment on that. In fact,
Yeah. Yeah, true. Actually, currently the TR is so severe, and the PA pressure. I think our accuracy would be good with the echo also. The correlation is quite good at this level of pH. Obviously, at a mild pH or a very mild to moderate level, obviously the cath is the gold standard. But with this amount of TR and the high velocity jets that we are getting, I think our accuracy would be quite good within 5 millimeters of each other. And looking at this pH of 80 mm of Hg, and secondly looking at the left atrial size, which is normal, and the LV diastolic function is normal, systolic and diastolic function is normal, and with the interatrial septum bowing towards the LA, we know that the LA pressures are very low. So this has to be precapillary pH. So I don't think the right heart cath would add much to it. So because we have the pressures which would be quite adequate from clinical purpose, and we definitely know this is a precapillary and not postcapillary pH.
Sure.
Yeah, I think.
Can I ask Dr. Burkali, would it be worth doing a pulmonary angiogram for this patient? Because of this question of AV malformations, which would explain two things. It would explain the pulmonary hypertension to some extent. They're very extensive. And the second is the very low DLCO as compared to the lung volumes. The lung volumes the DLCO is disproportionately low, which again fits with pulmonary AV malformations. And if you can pick up a few which are large, you can block them.
Yeah.
done.
Yeah, please go ahead.
Yeah, CT pulmonary angio was done.
Right, and
normal. There were no AV malformations.
Yeah.
No AV malformations. Okay. So where does the story of AV malformations come in?
Echo.
Yeah,
Bubble echo,
so it is
bubble echo.
because of I think very disproportionate hypoxia that she is having, disproportionately high hypoxia she is having right from the beginning of her disease process. It's not has worsened. It has always been very, very high cyanosis. And secondly, there was distinct bubbles coming into the left atrium from the pulmonary veins, which we could visualize. And so it cannot be refuted. And there was no PF also. So I think there was some kind of a right to left shunting going on in the lung to additional to this pathology.
Sonia, since you have to leave early, any thoughts, Sonia?
No, an incredibly complicated patient. I think your workup has been perfect. I wonder, putting it together, whether she has two processes, as you sort of alluded to, whether she has a diffuse emphysematous pattern for her biomass exposure, and she's now developed some sort of inflammatory lung disease. The things that I think would bring you more certainty in diagnosis would be potentially doing a BAL, because if she has a hypersensitivity, you might see a lymphocyte predominant BAL, as opposed to if this is a CTD, you might see something that is a polydominant. But the reality is that I think you're probably going to treat her the same way. And I think that there's probably a non-zero risk of trying to do a bronch on somebody whose pulmonary hypertension seems as severe as as hers is. I have to agree with you. My thoughts were more down the line of this being a connective tissue disease, just given the disproportionate degree of pulmonary hypertension she has. Um, I fear that the issue that's really going to drive her hypoxemia is actually her pulmonary hypertension. And so, my thoughts would be that, you can certainly you could certainly think about escalating immunosuppression, but it seems to me like you've got a reasonable, you've taken a reasonable course there. Um, I do wonder whether she would benefit from vasodilators. And the other thing I wonder about is, given her young age and presumably lack of other comorbidity, whether she might be a transplant candidate. And I don't know whether that would be appropriate, but I'd be interested to hear what others think as well.
That's all.
Professor Wells.
Sorry, I'm having some trouble there. That's better.
Yeah.
I think the more this case was presented, the more likely it seems that transplantation at the end of the day will be the major improvement in life expectancy. Very difficult to classify what's going on in the interstitium. The spirometry is restrictive, strikingly so. The FVC and TLC are way down. I think the TLC was about 45%, wasn't it? So very small lungs, diffuse microcystic change. It's very difficult to place this as anything other than unclassifiable. I'll say that up front. I don't think you could possibly, with an ANA, nothing else clinically, going for CTD, call it CTD. I suspect, though, that the ILD and the cysts are one and the same thing. Sonia may be right, there may be two disorders, but in that case, it's weird cysts we can't understand, plus ILD we can't understand. So I think I'd rather call it one thing we can't understand. And my working hypothesis will be that when you see this sort of emphysematoid destruction mixed in with ILD, you commonly do have one or another form of immune dysregulation. I've seen it certainly in hypersensitivity pneumonitis as a phenomenon, emphysema in non-smokers as part of an HP process. So if I had to plump for any one thing, and I don't think I get to 50% likelihood, it would probably be HP. But to me, you might or might not slow this down with some immunosuppression, but you know the outcome's going to be bad. So really all your bridging, if you can do it, is bridging to transplant here. Sonia, I think I agree with you that with the severity of this pH, I'm not sure we do a BAL actually. It does seem very severe. But if this is a diffuse ILD taking the form of emphysematoid destruction, but with a restrictive pattern that's very, very restrictive, I actually think the ILD is bad enough to drive the pH, probably. I'm not convinced that it's disproportionate. So I'm not taking you much further. You are already using an antifibrotic drug, which is sensible. You're thinking about immunosuppression, which might bridge somewhat, but you're working towards transplant, I'm quite convinced. And no, I haven't got any other tests to suggest. Sorry.
Yeah. Is it okay, Prahlad sir? Prabhudesai sir?
You're muted, Prahlad.
Yeah, just want to summarize that our impression is probably pulmonary hypertension as a predominant component. And as well as lungs are concerned, we are not very sure whether it's a CTD-ILD or hypersensitivity pneumonia. But as the treatment is concerned, I'm not still understood whether should we increase mycophenolate dose or should we add some amount of antifibrotics. So that I'm still not able to understand.
Yeah. I think the consensus was, Prahlad, neither is going to make much of a difference,
Yeah.
probably, but it may be worth, as based on what Nitin said, whether we should try pulmonary vasodilators and see if they improve the hypoxia. Did you try that by any chance?
Yeah, we have started on sildenafil, the only single drug.
And she's tolerating it well.
She's tolerating. Since LV is normal now, we have
And how
not
much are
worried
you
about.
giving her? How much are you giving her?
20 milligram 8-hourly we started, and now we are going to step up the dose.
Yeah, because he feels it's, group 1, all pre-capillary, in which case it's
Of
worth
course.
doing that. Yeah, I mean, I can't think of anything else.
So what I would suggest is you add endothelin receptor antagonist as the next step, instead of increasing the drug any further, instead of increasing sildenafil any further. It's a good idea to start with a combination with this severity of pulmonary hypertension.
Look,
Okay, and what about the mycophenolate? Should I stop it or should I continue using it?
I would continue it. And I'm sorry, I missed the dosing that you're using currently.
360 milligram mmF mycophenolate S sodium salt, 2 tablets in the morning and 2 in the night. That is equivalent to 500 milligram, 1 gram twice a day.
Yeah. So that's, I mean, unless she's rather large, that's probably a pretty reasonable dose. You could certainly push it up if you think she'll tolerate it from, the standpoint of her white count. But I think that's certainly a reasonable dose of MMF.
Okay.
I agree with that, but I would not underrate the lung disease here. You've got diffuse microcystic change. You've got a total lung capacity of 42% predicted. Now, neither of those is going to be due to the pulmonary hypertension. So I think we're saying the same things. You optimize antifibrotic therapy, and I would err, if she tolerates it, on pushing the immunosuppression up. But she's both got bad pH and she's got bad lung disease. And I think it's the transplant that's going to make the difference.
Okay.
Or blood gases, Prahlad? Is she retaining CO2 or?
No, she is not retaining carbon dioxide. She's just hypoxic.
Okay. Moving on to the next case, that is 65 years old lady from Kerala. She is a diagnosed case of idiopathic pulmonary fibrosis from outside hospital before she came here. Since April 2025, she was started on a small dose of pirfenidone, and she was also on inhaler. There were some history of fall and other non-relevant history. Pulmonary arterial hypertension was detected. She was suggested long-term oxygen therapy, which she just started for 1 month. She came to us somewhere recently, 1 month before, with tiredness, disturbed sleep, loss of appetite, and loss of weight. Exposure to biomass fuel, no other significant exposure. Her saturation on breathing room air was 91%, heart rate of 110. She was quite tachypnic, respiratory rate amounting to around 24, which goes on. Some anxiety component was there, but I want to label everything was secondary to anxiety. Echo was MVP, mild MR, concentric LVH, adequate LV systolic function, mild pulmonary hypertension. Her workup was done, CTD workup was done outside, which was, I repeated here. ANA profile, I believe it was negative. ANA was outside done, which was negative. This is her myositis profile, and if Mithun, you quickly comment on this, it will be great.
Well, just seeing the myositis profile, and the PL7 is 2+. It's significant positive.
Yeah, and she didn't have. I think you also saw this patient, right, Mithun? Did you find any symptoms of myositis in her?
No. She doesn't have any features of myositis clinically.
Yeah, clinically she doesn't have, but this was the report. And do you remember ANA we did here? We didn't do, right?
I'm not sure.
Yeah, I also don't know. But ANA was negative outside, ANA profile was negative, myositis, PL7 was strongly positive, and I believe CT scan at this point will be interesting. Yeah, Aparna.
Yeah, I'm sharing.
As the images come up, Smita, how long is the history?
So
Total?
they are telling it is hardly 1 year history. Suddenly she worsened. They are saying
She was
that
absolutely well a year ago.
I won't say absolutely, but they are telling that for last 1 year only she started going and seeing doctors this
Sure.
frequently.
Sure.
So CT is actually from May 2025, and we are seeing subpleural predominant reticulations, and in the lower lobes we are seeing honeycombing. So it's looking like an ILD with the UIP pattern. At the time of the CT, she had some pneumomediastinum also. And at the time of the CT, pulmonary artery size is within normal limits on the CT. It's 26 millimeters, and there was no RARV dilatation also at that time. Some other incidental findings that fracture, humerus, gallstones, etc. is there, but mainly it is like a UIP pattern.
With a pneumomediastinum.
Pneumomediastinum in May, yeah.
So in May she was admitted with exacerbation, infective exacerbation. That is what they told, and since May only this treatment was started. Okay.
And she wasn't on steroids, right? The pneumomediastinum, I was just wondering. No.
No. That time maybe she was receiving some short course of steroids, but presently I started increase the dose of perfenidone, and because she was very very emaciated and all, I thought I'll give her a short course of steroids for 5 days. Now question is, Aparna, you told it is UIP pattern, but my interest will be, I saw there was exuberant honeycombing. You went very fast, and what I saw in the CT scan was there is significant exuberant honeycombing in bilateral lower lobes, and the distribution is quite specific for CTD ILD, or you feel it is IPF kind of ILD, not CTD ILD kind of ILD. And Mithun has answered that he doesn't feel this is myositis related. So my question is like,
No, ma'am. There is no myositis features clinically.
yeah,
PL7 is positive, strong positive, and pneumomediastinum,
goes
the
in
only
favor of.
ILD with pneumomediastinum in our disease is the dermatomyositis.
Yeah.
No other ILDs will produce the pneumomediastinum. They can produce due to other reasons, but classic.
And PL7 is not for dermatomyositis. What do you say?
It's for myositis. It is for antisynthetase.
Antisynthetase, right? So
Yeah,
we have
CT
some
wise also
features.
it can fit. There is significant honeycombing and it
Yeah.
can be a CTD UIP.
Yeah, so the question is like, should we, what is the diagnosis? Is it CTD related ILD? And should I combine, like, because she was on perfenidone low dose, I increased the dose to a standard dose, but what should be the line of treatment in the future? Should we add more immunosuppression? Sonia?
I think
Yeah, I think
wait
this
for
is
Sonia to answer this because
Yeah,
how the weightage for that PL7 is the key issue, I think.
yeah.
And, Mithuna said clinically she's okay. Sonia?
Yeah, no, I think that this is a great story for somebody who's presenting with PL7. It's the abrupt onset of symptoms. It's that kind of, as you pointed out, the exuberant honeycombing. It doesn't look like the kind of UIP
Yeah.
that we see in IPF. She's a young woman. So I think that this is, and the pneumomediastinum, I agree, is very classic for myositis-associated ILDs. So I think that she is very likely to improve with immunosuppression. And I think that you had pointed out that she was fairly hypoxemic and tachypnic when she was evaluated.
Yeah.
So I would start with upfront, probably steroids, oral steroids, and I would add mycophenolate to that and, look for improvement in her pulmonary function testing over the first 3 to 6 months. And if she's not getting better, I would probably add on a second agent. And the second agent is kind of choose your own adventure. So it could be rituximab, it could be IVIG, it could be really, I mean, many other things as well. But I would be hopeful that she's actually going to turn around and do a lot better with immunosuppression. Now, in terms of the role of an antifibrotic, I still don't have a really good sense of where antifibrotics are valuable in this setting. I'm interested to hear what others think about this, but I would certainly, if it is an issue of drug tolerability, and if she's tolerating the pirfenidone, great, and she can tolerate it alongside, steroids and a steroid-sparing agent, I wouldn't worry about it. But if she can't tolerate all of them because of GI toxicity, I would give up the pirfenidone first. And then the other thing I would add, which we haven't really talked about, but I should have mentioned, is just pneumocystis prophylaxis. I'm not sure how common it is we're in India, but we see enormous amount of pneumocystis in these patients. And so for anybody who is going to be over 20 milligrams of prednisone for any period of time, we start pneumocystis prophylaxis.
Yeah, she is on. She is on. I'm sorry. So the reason we both discussed, myself and Mithun discussed that he's my colleague in the same hospital. So we both discussed that because she has got exuberant honeycombing, whether immunosuppressant will help, because this kind of disease usually behave like IPF. So whether our immunosuppressant will be helpful even though PL7 was positive. That was the only reason that we put this case for discussion. So that is the
It was interesting, Asmita, when Sonia mentioned that she wouldn't be that gung-ho on the antifibrotic,
wow.
which I think would be sort of almost like a give-in, right, Prahlad, with this CG in India,
Yeah.
because we probably so your thoughts on an antifibrotic, Athol?
I think we're seeing enough of the UAP pattern here that I would be very
Yeah.
comfortable using an antifibrotic in addition to everything that's been laid out. Of course, it's a question of what is tolerated, but I put a reasonably high premium on adding that because of the fact there's a UAP pattern there.
Yeah.
And
Athol and Sonia, because I think we'd be hard pressed to feel that the train has left the station, not prescribing an antifibrotic. Are we going to be missing out here in India? And I think the ease of prescription, I think, Prahlad, that would be one of the reasons we probably get on it. But it was interesting to hear from Sonia that there are patients with this type of honeycombing that she'd wait on, which is
Absolutely.
And second doubt was I started on an oral steroid thinking that only, but do you think should I admit her and give her at least some 500 milligram of Solumedrol or something? Will it help? Because fibrosis was so much predominant, didn't consider it. That is the second doubt.
I think she probably still has a fair amount of inflammatory disease. The one thing I would sort of put in your thought process is that we have actually seen patients like this who, when they're given high dose steroids, actually worsen their pneumomedistinum. So if she's clinically stable, I would use oral steroids. If you think that she is declining, I would never hesitate to admit to pulse her. And as we talked about while I was there, I mean, we use IVIG up front, but again, it's just going to depend what you have available for her. But if you have any sense that she is declining, I would certainly admit her and give her a pulse.
Sure. Any Rajan sir, Murli Mohan sir, anybody wants to add anything? Otherwise, I'm good with Mithun. Next visit, maybe we will add on MMF or something. I think that will be the best way to go.
I think we have added microphone late.
You have added. Okay,
Yeah.
fine. So moving on to the next case. This is another interesting case. She is a non-case of rheumatoid arthritis labeled from outside, came here, 71 years old, non-case of ILD and hypothyroidism. Rheumatoid arthritis for 12 years on medications for last 11 years. SP total knee replacement in 2024 post-COVID. Presented with dry cough for 3 years, more for last 10 days, but now she has productive cough also. Breathing difficulty, which is aggravated on lying down. Her cough worsens on lying down. Grandmother had asthma. Saturation 98 on room air, 104 heart rate, BP was stable. This is our spirometry, 7986 ratio of 86.5 in May, and in September it went to 109 from 7684. 97% was her DLCO when it was done outside. I don't have minimum desaturation out of 97. She went to 88%. Tachycardia was present during study. She came to me for second opinion because of infection. Somebody suggested her lobectomy. With that thing in mind, we have to see this CT scan, that she was advised that you undergo lobectomy so your problem will be solved.
So we have two CTs. One is from May 2025 and the other one is September 2025. So the May one is partly expiratory. We don't have a proper inspiratory scan, and in this, what we're seeing is whatever we're seeing like ground glass opacities could partly be because it is expiratory. And in the left lower lobe, we are seeing a small area of honeycombing. But it's very focal, small area alone. And there's one more small, similar but very small area, which is in the right lower lobe, which could partly be related to adjacent big osteophytes are also there. So that may be some osteophyte related changes. So rest of the lungs are kind of okay within that limitations of the expiratory scan. So the September scan is a good inspiratory scan. And here again, we are able to see this one area of honeycombing that we are seeing in the left lower lobe. Very focally that it is there. Rest of the lungs are pretty normal. Again, we are seeing that same another small area of honeycombing in the right lower lobe, and rest is all fine. No nodes and no pulmonary hypertension, and nothing else significant. So I don't think it is any ILD. So it could be some form of whether it's like a post-inflammatory sequel with some form of scarring which is left behind this area of honeycombing, or whether it's some kind of congenital like CPAM or those kind of anything. Those two things I can consider.
Okay, what I was thinking was it the islands of fibrosis, which is also reported in a case of CTD ILD? Because I was seeing the very few areas of earlier. I also thought this looks like bronchiectasis rather than ILD. I actually ruled that out, and I told no, surgery is not indicated. 71, not a good performance score. And then the second CT they brought, and then I was just because rheumatoid arthritis was the first diagnosis when 11 years before. So is this a island of fibrosis which is reported in typical CTD ILD, or is this bronchiectasis? I didn't able to trace. I was not able to trace the bronchi. So bronchiectasis was not my diagnosis.
Yeah, I don't think it is bronchiectasis.
Okay.
It's some kind of, yeah, it's more like one area of honeycombing. Island of fibrosis is possible, but those are like multiple small islands. This is like one big area and then just another small area in the right lung. The rest of the lungs are looking so
Even
clear.
that upper part of like it's not only the right lower lobe. There was somewhere other
Okay.
areas also, no honeycombing of. If
The
you will
left
go
side of the
slightly slowly, that you might see that. Yeah, there upper, almost just above the liver, above the diaphragm and liver, kind of.
No, nothing is there here.
Yeah, some there,
This one
yeah,
focus, yeah. Here one
know,
focus is there.
yeah. So because I saw multiple, so that is why I felt that is it CTD. So the questions were that only that first of all, patient was referred here for lobectomy, whether we should suggest, because if it is CTD related problem, I will not suggest that. And what will be the management? Should I just keep her under observation? 97 room air, and even spirometry is not bad. She's not desaturating. Only concern was, is the infection because of the secondary to the left lower lobe problem?
These are tricky ones, yeah. And there's no history of infection in the past either.
Only for last 1 year she started worsening. The doctor who is treating is also quite good. I just started on tobramycin nebulization and some erdostin and all. That's what I have given.
Is she growing
Yeah.
pseudomonas, or she's colonized with pseudomonas?
not at present. I just gave her on OPD basis because I was not giving any other oral
Sure.
antibiotics.
Sure.
And my doubt was like, is it islands of fibrosis? And
I
clinically,
haven't. I have
yeah,
to admit, I've never seen such islands, small islands of, except in the post-infective scenario. You
yeah,
sometimes get these islands, but Athol, Sonia, Prahlad,
yeah,
Murli.
that's it. Nothing from me.
Okay, I want to be reassured this is not a malignant process, actually,
Okay.
because at the moment we're being given snapshot imaging without the big time interval. I can't place this as I'm comfortable with a primary ILD here. I have seen pseudo honeycomb change turn out to be a malignant process. She's had rheumatoid for 12 years, so I'm supposing there's some old imaging, even if it's chest radiography.
There will be, sir. Yeah.
Not all, I mean, many of our rheumatoids are not scanned, Athol.
Yeah.
So they may not
No,
be old imaging also. Yeah.
Can
they're
micro?
just
Sorry. Yes, sir. You can talk.
Oh no, I was just asking about an old chest X-ray, basically. I mean, I'm not saying that malignancy is the top
There
target
might be. There
diagnosis.
might be chest X-ray, sir. I can dig it out. They are in contact with me. I can find out whether chest X-ray will be showing this, or any changes. I'm not sure.
Can micro aspirations give like this from
Left lower lobe.
reflux?
It
Lot.
is
Left,
seen
even
well,
patient
yeah.
also has on the right side to some extent.
Yeah, very little on the right.
Little.
It is
Lot
seen well
depends
on the
on
topogram, so it should be seen on the X-ray.
Yeah. So it should be seen on an X-ray. So Asmita,
Yes,
get
yes.
those old X-rays if we can. And Sonia, do you see this in CTD ILD, this kind of pattern?
I've only seen this in individuals who have a history of a severe lung infection and they're left with an area of bronchiectasis, and then they get immunosuppressed for their CTD, and then they develop kind of like a wet bronchiectasis. So one of the questions I was going to ask for the radiologist is, do you do coronal reconstructions? Because sometimes that's helpful especially in something like this where it's a little bit hard to see if there are airways attached to it. It's sometimes a little easier to see it in the coronal reconstructions.
Yeah, sure, I can show that.
And in which case, if there were airways attached, Sonia, you would think more of post-infective?
Right, exactly. And then I would treat her as a bronchiectasis.
Right.
It's a little difficult because the bronchi are running close to it,
Yeah.
and some of them are connecting up and joining to form elongated structures also.
I would be curious if she had a severe pneumonia as a child or in her earlier years, and maybe this has just been the residual. And so now the other thing I'd be interested in is if she has normal immunoglobulins, because the other thing we see is a lot of emergent common variable immunodeficiency as people age. And so people who have managed to maintain with these abnormal areas suddenly become infected just because they're starting to lose their IgA production.
Okay, I'll find that out. I think that can be doable. Immunoglobulin profile. Until that, I can treat her the way I'm treating, right? Like antibiotics and bronchodilators. Okay.
Can
Do
I just
any?
make a comment? Is that and again, interested, Ethel, in what your practice would be, is we would actually give her low doses azithromycin rather than inhaled tobramycin as her suppressive therapy, largely because it's also anti-inflammatory. But
Sure.
again, I'm not sure whether that would be the same practice in an area where you have potentially endemic TB. So I don't know, Ethel, your experience in that?
Would also go with azithromycin, I think, here. And it would be very much a monitoring policy. I'm still slightly bothered about malignancy underlying this, although it's not by any means the most likely, but it's a bad thing to miss. And so I'm reserving judgment till you've got some of the old films back.
Yeah,
And the
azithromycin
future
is,
imaging
sure.
and the future imaging in about 6 months to see what's happening with the
Yeah.
Okay.
I
Okay.
don't want to scare people too much with this. I think malignancy is still unlikely, but I think we should have it on the table as a possibility.
Okay, sir. So azithromycin is, I think she was already on azithro by the time she came. The doctor treating was giving, and maybe that was the reason. Otherwise, I also usually give azithromycin prophylaxis more frequently than I give tobramycin. And mostly they expect you to change some medicine when they come to you. So maybe that was one of the reason that she got tobramycin from me, nothing else. Okay, moving on to the third case from my side. This is a 52 years old lady, again from Kerala. She was diagnosed as thoracic sarcoidosis in 2017, and she has also labeled as bronchial asthma and treatment for that. In treatment history, she was given deflazacort, starting with some 18 milligram and then early tapering, and 6 milligram was the maintenance dose. Then added methotrexate in 2019 and MMF in 2020. Interestingly, she was first diagnosed as extrapulmonary tuberculosis. Before 2017, she was started on sarcoidosis treatment. She was given anti-TB drug also. So 1 year TB medicine and all these drugs. She has persistent cough, dyspnea on exertion, and generalized pain in abdomen. She has actually stridor rather than wheeze. That's what I would say, because whenever she's talking very fast, I can hear stridor. Saturation and vitals were stable. Calcium level was 9.4, LFT normal, nothing great in even her CBC. EBUS was done in March 2017 as the first time when the diagnosis was done. It was a granulomatous disease. BAL was taken, which was negative. ACE levels were always on a slightly higher side, which became 59 in 2024, which was last measured. And then we will see the CT images and then I will tell the questions. Yeah.
Yeah, I'm just sharing. So we have three CTs for her, one from 2019, another 2023, and another one now in September 2025. So in 2019, we have these conglomerate parahilar opacities with multiple tiny nodules around it. So this is quite typical of sarcoidosis, and she had lymph nodes also at that time. 2023, there was definite improvement with some residual changes that we are seeing. So this is kind of similar area, but some residual changes, but improved. So 2025, it looks like again it has worsened. So looks like there is a relapse. The lymph nodes also had reduced and have now slowly, mildly increased in size again. Do you want to see the notes? So it's fine.
No, the problem is now, I felt the endobronchial obstruction is so severe to cause stridor, and the reason I have brought this case is like when she was on methotrexate, she was doing okay, and then if we see the bronchus, both the side, the right main bronchus and the left main bronchus, both are like surrounded by the lymph nodes, and I am worried about that. Is there any way we can, like, because is it fibrosed lymph node? Is it fibrosis or is it lymph node which is causing all these problem? Because if it is fibrosis, there is no point of hiking up of steroids. But if it is a lymph node which is causing, then maybe you can see the soft tissue window,
Yes,
and
yes.
maybe we will able to, because that is the reason that sarcoidosis, how we should treat. Is it fibrosis which is causing this much of stridor, or is it lymph node which is surrounding the airway?
I think it is part of whatever the granulomatous disease, which may be parenchymal plus nodes put together. I'll just put the nodes, but I'll just show once the airway before that. So in 2019, the main area which is more severely narrowed is the right middle lobe, which actually opened up in 2023, and it's again getting narrowed in 2025. So that is one main area. I'll just show you the nodes. So this is the 2019 one.
19.
So these are the nodes, but I don't think it's just the nodes. It's nodes plus this parenchyma. Everything is formed one conglomerate opacity. So right upper lobe also mildly narrowed, but the predominant thing is this middle lobe one, which is getting narrowed, which had improved in 2023. So I think it should improve, hopefully.
And you have no biopsy at all, right, Asmita, at any stage?
No, proven, biopsy
proven.
proven, sir.
Yeah.
Biopsy proven. EBUS TBNA was taken in 2017 before diagnosis. She took ATT also, sir,
Okay.
before starting.
Bronchoscopy wise also, was it like, are there
So
granulomas within the bronchi or?
So they have written that right middle lobe, as you told, right middle lobe is showing significant narrowing and all, but that was 2017 bronchoscopy. After that, they have never repeated anything. Recently also, yeah, they didn't repeat. She just came for second opinion. These are all done outside. So I was
There
just
may be
wondering.
some degree of this EDAC also, excessive dynamic compromise of the airway. It's getting narrowed in the expiratory quite a bit. That component may also be there.
But you've got stridor, you've got inspiratory compression. I thought you said there was stridor.
Yeah, so
I don't think you should just. I don't think you should just assume that the narrowing is all fibrotic.
okay.
And sure, you see this progressive massive fibrosis look like, but unlike the other fibrotic phenotypes, you can never be quite sure how much of that may melt away with treatment. We already know that some of it did regress. So I don't think you can look at those images and declare that the impact is pure fibrotic.
Okay.
It did
Asmita, do you
open up
have
once
any,
earlier, didn't it?
Sir?
Asmita, do you have
Opened up
flow
once
volume
earlier,
stuff?
so we can still reverse it, I think.
No,
Got to try to. You've definitely got to try to.
okay. You want to see that there is a intra or extra. I was
Extra
thinking,
off.
I
Maybe
will have a look
sometime
on that.
that
Yeah.
vocal cords maybe stiff, maybe in the median position.
Okay, so this people have done every investigation from outside. I will just check whether whether they did it from here.
Did you show us lung function tests at some stage? I may have switched off and missed them. I'm sorry if I did.
No, I didn't show. I didn't show it. I'll show it. I think we didn't do it here. It was always done outside. I might repeat it. Yeah.
Sure.
Yeah, it's not there with me. And as I told, she was given some 2017 deflazacort. Methotrexate was added in 2019, and since 2020, I think they told on methotrexate she was not improving, so they started on MMF. And presently she is on deflazacort very minimum dose around 6 milligram and MMF dose 1 gram BD. That is what I remember. And questions are, is the airway narrowing primary inflammatory or fibrotic? Sir told that we cannot make out from the CT. So should we reintroduce methotrexate or any other immunosuppressant, or should I just hike up steroids? And interventional procedure intervention will help for relieving her airway narrowing. Do any of you think that that will be a great idea, or should I go on medical treatment part?
She's normoxemic on room
I
air.
would reintroduce.
Yes, she is 97 on room air, sir. See, so when she talks, she is a teacher. So what she's telling is, when she is talking continuously, she talks. And then that is the reason that she, even in spite of this many years, she didn't improve. So she came to me.
Do you think Athol, Prahlad, Sonia PET scan would influence your decision?
Well, I'd like to know the lung function tests.
Yeah,
and
lung
also, it was said in the past, and I saw it played out, methotrexate is sometimes particularly effective with bronchial stenoses, airway-centered fibrosis. It was interesting that after being on methotrexate, the right middle lobe bronchus expanded, and off methotrexate, it's now contracted down, the fibrotic or fibroinflammatory mass has reaccumulated. So I would go for methotrexate. The scan does influence me because you're so clearly dealing with major airway obstruction. and you have a track record of having been on methotrexate, clearance of that, come off methotrexate, and the problem recurs. But your question, would the scan otherwise influence you? Well, I put it together with the lung function to decide on the level of danger for the future as well. But it's certainly not looking encouraging, is it?
It's just that with the inspiration slider, I wouldn't have the courage to go with only methotrexate. I was just wondering whether we should pulse her or give her a larger dose of steroid as well.
I would go for a short, sharp course of steroid to establish whether there's reversibility, and then I would still settle in with methotrexate in the hope of a longer-term response. It's just by virtue of seeing surprisingly good responses. And we don't these days often encounter endobronchial narrowing to this degree in sarcoidosis. But in the past, where I've seen it, methotrexate has often been quite effective.
Sonia, Prahlad?
Yeah, I think first we should visualize the airways, vocal cord functions, tracheomalacia, which has been shown, whether it's really significant. And of course, the pulmonary function test, good pulmonary function test will help to understand the physiology, what is happening. Lungs are not so that bad as well as HRCT is concerned. Okay.
Would you do a PET CT, Prahlad, before treatment? No.
No, unless you want to add infliximab and we want to differentiate inflammation versus fibrosis. Probably you can think about, but
I was thinking of a PET CT from the baseline point of view, because now you're changing track. She's never had a PET, right, Asmita?
No, she didn't have PET.
Sonia, what would you do?
I'm still perplexed about. I think I agree with Athol. I think that I would reintroduce methotrexate. I think that it's a very interesting question about whether imaging in a different way is going to be valuable. Part of what I can't decide is if the issue we're talking about is actually that airway narrowing, or if there's something proximal to it. And so I also agree. I would probably have somebody scope her. I mean, either ENT to scope for upper airway, or else to do a bronchoscopy where they're very careful and look at the airway before, look at the vocal cords before they go through, because it just sounds like there may be two problems here. And I know Athol only likes one problem, but it does sound like two problems.
No, not at all.
I think the other thing, and I think Athol was maybe alluding to this, is like a really good flow volume loop might help us here, because he has a very flat loops, and so we're going to be looking for, an obstruction. But clearly something needs to be done to try to control the narrowing around that airway, because eventually that's going to, if it progresses, it's going to be devastating for her.
I was also worried about that. And nobody thinks that interventional pulmonology is a good idea, right? Something like dilatation or lesser, or because
you may be driven to that, and we have been. And that is one good reason for getting photographs of what you've got now and seeing what it is does change, and going back and looking again with bronchoscopy. Yes, Sonia, I must confess I was doing the full flow volume evaluation as well. So I wanted lung function before deciding anything.
I'm sorry,
but no, there's stridor there. And so you've actually got to have a look.
Yes.
I cannot see many Indian pulmonologists going with methotrexate reintroduction alone with stridor ongoing. What do you feel, Prahlad?
Yeah, you are saying is correct. Once the methotrexate has been tried and it's failed, nobody will try again.
No, it helped. It did help in the past.
It helped.
It helped. But the question is, with stridor, to try it alone is very reassuring to know from Athol and Sonia that could come back on.
If there's a stridor, I prefer to give a dexamethasone to you. And
many of us would, but I think we're moving away from that treatment paradigm. Yeah.
No, but I think
I would also give a trial of methylpred here.
Sure.
And that would be to buy in this patient's not getting more than 3 months to 4 months of steroids.
Sure.
But you're actually trying to improve rapidly.
Yeah.
But I don't think I would hold off doing the other tests.
Sure. Murli?
No, that's exactly what I was going to say. I'd do the, the flow volume loop, look at the upper airway, give a short burst of steroids, not a pulse, and introduce methotrexate after that. But that's I think the way to go.
Sure.
Good evening, everyone. I'm Dr. Sean, as well as Dr. Adira from Astromedicity, and we are on behalf of Dr. Elizabeth Swimla. Unfortunately, she is on an exam duty today. So here we will proceed with the case.
65-year-old male who's a retired government clerk with progressive dyspnea for 4 months, worsening from grade 1 to grade 3 MRC. With no history of fever, chest pain, or hemoptysis, no smoking, no previous history of TB or bronchial asthma, and no significant family history. Ma'am, I cannot change it to the next. On examination, he was hemodynamically stable, maintaining saturation of 94% in room med. Otherwise, at the examination there was no significant findings, and on systemic examination, he was found to have bibasilar respiratory capsules. Other systems were normal. On investigation, routine blood investigations were within normal limits, with CRP and ESR was negative. We did an echocardiogram, which showed grade 1 left ventricular diastolic dysfunction. And moving on to the CTD workup, the workup done was inconclusive. We did a myositis profile as well, which showed ANA was negative and myositis profile showed weakly positive PL7. On pulmonary function test, it showed a restrictive pattern, and we did a DLCO, which showed restriction with diffusion limitation. The chest X-ray that on 6-minute walk test, we found that there was a 79% on room air saturation drop, and we did a chest X-ray, which showed bilateral lower zone reticular opacities, which led us to doing a HRCT.
So this is a HRCT from April 2024. So we are seeing some mild bronchial dilatation. There are subpleural reticulations in the upper lobes. And as we come down, we are still seeing some mild bronchial dilatation and a lot of bronchial wall and peribronchial thickening that we are seeing. In the lower lobes, again, there's quite a bit of all these areas of bronchial wall and peribronchial thickening. There are reticulations, ground glass opacities here. And again, reticulations, ground glass, mild traction bronchiectasis, no real honeycombing that we are seeing. And again, this patient also has pneumomediastinum. We can see all these areas of pneumomediastinum. Pulmonary artery is not dilated, and lymph nodes are just small subcentimetric nodes only. So maybe I should just show the coronal. So this is the coronal showing the similar findings, the lower lobe predominant reticulations, lot of bronchial wall thickening also, and traction bronchiectasis, and all this is the pneumomediastinum. So I'm thinking whether there's like a combination of this airway plus an ILD, because a lot of bronchial wall thickening component also I was seeing. So ILD wise, if we go by the pattern, maybe it is like a fibrotic NSIP, because there's a lot of ground glass also and not much of honeycombing. and whether we should consider CTD-ILD, and again, because this pneumomediastinum is also there.
Yeah, would you call this a straight edge sign also?
Not particularly, I think.
Not really.
Maybe we can kind of extrapolate it to that.
And the autoimmune workup is negative from Astra?
Yes, sir.
Just that PL7, which was mildly positive, is that right?
Yes, sir.
Borderline.
Is there any obstructive component at all? It's only like I was just wondering because of the bronchial ball looking thing.
There was no significant obstructive component.
Okay.
The patient was mainly complaining of dyspnea and cough.
Is there any hiatus hernia?
Looking.
Maybe there's a small hiatus hernia. There are features of chronic liver disease also. Sorry, I forgot to mention that. Liver has very heterogeneous and nodular surface and all. Chronic liver disease is there.
Following which, we did a bronchoscopy and cryobiopsy. In the cryobiopsy, we could find mild interstitial changes with focal lymphoid aggregates.
Hello, are you able to hear me?
Yes, we can, Sharda.
Yeah, yes, sir. So this is the cryobiopsy. What I could find in this cryobiopsy is there is mostly this bronchial wall and very scant alveolated lung parenchyma. Most of it is, if this is the only biopsy fragment, then it is mostly showing the bronchial wall. There is one lymphoid aggregate on the right side, and the left side there is very scant alveolated lung parenchyma. Yeah, so this is the lymphoid aggregate. And most of these cells are, they are lymphocytes. I couldn't find any granuloma here. And the interstitium is also showing scant inflammatory in the previous picture. And in this picture, it is showing there are lymphocytes. I couldn't find more of plasma cells. Most of these are lymphocytes. Along with that, there are few clusters of histiocytes. I couldn't find any eosinophils. In this, there is no increase in plasma cells. And here again, there is this very scant alveolated lung parenchyma and these lymphoid aggregates. There are no reactive germinal centers. So I really do not know whether I can make any specific diagnosis based on these pictures. But lymphoid aggregates, they are seen in CTD-ILDs. But again, I couldn't find any NSIP pattern, or I couldn't find any increase in plasma cells in these pictures. And I don't know whether drug-induced ILDs can produce these lymphoid aggregates. Another thing is SRIF also can show lymphoid aggregates, but this patient is not a smoker, and I couldn't find any other features of smoking-related ILDs also. And
you have a lavage from Aster, but you have a cytology to rule out malignant cells, but you don't have a differential count, do you?
We didn't do a differential count here, and the BAL cytology was negative, sir, for malignancy.
so drug-induced, to call it drug-induced, actually, drug-induced ILDs, they have a variety of patterns, but none of these patterns are specific. So like amiodarone, if it is amiodarone, there are certain drugs which can produce certain changes. Like amiodarone can produce foamy change in the epithelial cells, in the alveolar epithelial cells, and there are foamy macrophages. Some drugs cause OP. I couldn't find any OP in this. Some drugs cause NSIP pattern of fibrosis, which I am not able to see in this. And eosinophils, some of them caused eosinophilic pneumonia. I couldn't find any eosinophils in this. So maybe my first differential will be, I mean, correlating with the clinical and radiology, maybe a CTD-ILD could be a possibility.
Sure. Thanks, Sharda.
Thank you.
Can you continue the case?
Yes, sir. After the bronchoscopy, he was extubated after 2 days and he was discharged home on antifibrotics. And even after an extensive workup, the diagnosis was inconclusive. On the 9th OPD visit, when he came for review, we found that he had pedal edema and facial puffiness. On revisiting the history, we were found to have that he gave the history of tap nitrofurantoin and tap torsemide intake since the last 2 years in view of his urological problems. He had a history of urethral stricture.
Oh, that certainly changes the differential.
And on follow-up, we had after that OPD visit, we stopped nitrofurantoin, and after 6 months, the investigations were carried out to check for resolution. On the comparison chest X-ray, there was resolution of the bilateral lower zone reticular opacities, and the PFT also showed improvement in restriction.
So here, some of our questions from this case, anyway, it underscores the importance of how important is the clinical history in a patient. And so some few questions. Was it possible to, retrospectively, was it possible to identify the possibility of a drug-induced ILD from the radiological as well as histological pattern?
So Athol's question is that with a drug-induced ILD, I know his answer, any pattern. Any pattern is possible, but and this included. Athol?
Well, I got thrown out to come back, and so I missed the scan. But when I was thrown out, I was just beginning to see the combination of some airway abnormalities and some interstitial abnormalities. I'm not sure what that turned into on review. No, I'm afraid the range of drug-induced patterns is very wide. Sometimes it's helpful that the distribution is random. I think that's always a clue, but I don't think the distribution was random in this case. On the first 15 seconds of the scan I did see, it looked as we're dealing with predominantly lower zone, predominantly pleural abnormalities. So I think the moral of the story is never make assumptions about patterns of disease with a drug. And no, I wouldn't go using an antifibrotic drug if you think you're dealing with drug-induced disease. And what you did was all very logical. I'm not sure that I can answer anything else on your list of questions.
Probably if you picked up that history, maybe you wouldn't have done the biopsy, I guess, right?
Yes.
In retrospect.
Right. Prospectively, we would not have. But even after initial clinical visit, we asked about the drug history. Of course, we asked about the environmental exposures, but it was denied.
It's fine.
Probably because of the fact that he might be
But
taking the medicine for so long that he didn't mention it.
But it's good to see the pathology anyway, because it teaches you a few things.
What did the pathology actually show out of interest?
Lymphoid aggregates, not classical with germinal centers, no eosinophils, but a lot of lymphoid patchy areas, like this.
One question still remains, why there is so much inflammatory bronchi?
You mean why the airway?
Airways are, yeah. Because that's a predominant finding, important finding on CT as well.
Yeah, but do you think that could reverse? Because we don't have a fresh scan. They've got X-rays. And I'm just wondering whether a fresh scan would show some reversal there, Prahlad.
Yes, sir. He's under follow-up and we are planning to do it on the next visit.
PFTs have improved. So it's good to see.
Clinically also the patient is improving.
Super. So this is my case, 74-year-old lady, homemaker with 2 children living in Delhi. Thank you, Sonia, for being there. And we hope to see you next time with us all and everyone else. Thank you. So this is, she is residing in Delhi, more in Mumbai of late. and complains of the dry cough for the past 3 months and leg weakness for the last 1 month. Breathlessness, more weakness, sorry for that typo, it's more on fast walk. She feels more weak. Relatives notice her to be more short of breath, was unable to climb stairs easily in Bikaner, in Rajasthan easily, and knee joint pains for the last 2 months, better with steroids. She had hypertension since 2005, cervical spondylosis, and has depression. And she has a sister who died of fibrotic HP at the age of 52 who had a parrot. These were her saturations, and she has bilateral basal inspiratory squeaks. These were her autoimmune workup. CPK was okay, aldolase wasn't very high. ESR, ACE, ANA was 1 in 100. And the HP panel showed up alternaria and pigeon antigens. Echo was normal. The myositis profile showed a PMSCL 75 2 plus. With a lot of these bits and pieces here. She was seen by me 3 weeks after nintedanib 100 BID was started and prednisolone 20 milligrams a day, and she felt 50% better. Next slide. And that's the workup that we got done when she came to us 3 weeks after starting treatment. That's her, and this is her lung function. Vital capacity is definitely a bit low. DLC was 43% and she desaturates to 90%. And her CT is Aparna?
Yeah. Sorry, just, yeah. So she has two CTs, but they're just 1 week apart. So I'll just show 2 weeks apart.
Yeah,
So I'll
just
just
show
show
the
the
latest
recent
one.
most.
Yeah, the recent one.
So here we are seeing subpleural reticulations. Small cysts are also there, which is involving both upper lobes and lower lobes. There are some areas where they are where the lung is free and like almost like lobular areas of sparing. I think these areas do show a little bit of air trapping. I'll just show the expiratory soon. And as we come down to the bases, there are these areas of focal areas of honeycombing and traction bronchiectasis. So there is definitely fibrosis, and there is some kind of gradient, but upper lobe and lower lobes are involved, but and little more in the periphery. There is an expiratory. So this is the expiratory, which does show some areas of air trapping. So I'm thinking of whether it is UIP pattern itself or like a HP, fibrotic HP with HP, UIP, HP type of pattern.
Sure. That's what what confused me was the PL7. I asked her to meet a rheumatologist. I don't think she's yet come back with that opinion. Mithun, anything on that PL7 that you would read a lot into?
ANA is also positive, no? ANA, then what about the ANA profile? Have you
Blot was
done?
negative. The blot was negative. ANA was 1 in 100 nuclear homogeneous.
ANA blot also has this PMSCL. Now our ANA blot contains this PMSCL. If both contains this positive PMSCL, then it's very significant.
Okay.
It's a suggestive overlap syndrome, and myositis. There's some muscle weakness, no? And CPK can be normal.
CPK is normal. She has weakness, but she's also got these HP antigens coming positive. And so, though I'm waiting for her to see a rheumatologist for a clinical examination also.
Yeah, clinical examination is vital in this.
Yeah,
this patient.
I'm waiting for that. Again, because she's lost so much of vital capacity, Prahlad and Athol, I have upped her dose of nintedanib to 150 BID. But I'm just wondering, she got worried about the side effects of steroids and just stopped them, but she felt better. Should we do a BAL for her? Would you agree? That's what I was thinking of, getting a lavage done and my working diagnosis was fibrotic HP, but is there any different opinion or do you think we should work up any other way? She's 74, and that's her lung function. Yes, Athol? You're muted. You're muted, Athol.
Yes, I'd increase the nintedanib dose. She's got a UIP pattern. My working diagnosis is fibrotic HP, but I suspect she's one of those cases we see from time to time where you have both fibrotic HP evidence of a connective tissue disease. And I don't know if the connective tissue disease goes with epithelial damage. It makes fibrotic HP or H in general more likely. But I think we see too many patients HP and also have a connective tissue disease. So I suspect you're dealing with that combination. And I wouldn't go to disqualify the connective tissue disease. The inspiratory sweeps point very, very strongly to fibrotic sensitive pneumonitis. I've yet to hear them in a connective tissue disease with a combination of fibrosis and airway disease. I will sooner or later, but the inspiratory sweeps are very suggestive. The family history is interesting, but all in all, I agree with you completely. Now, when it comes to a lavage, I suppose if you find a lymphocytosis, it does reinforce adding something along the lines of immunomodulation. Whether you actually use steroids or just have her on mycophenolate, which I think would be reasonable. But the trouble is with the family history, you're more likely to run trouble with immunosuppression.
Yeah. That was
family history of a form of pulmonary fibrosis. So that's the concern. So that's probably why you feel you need a BAL in order to justify doing that. But you might be driven to use mycophenolate anyway if she meets criteria also for a connective tissue disease.
Yeah.
So in a way, the decision was made for you in that case.
Sure. Athol, if we had a bar lymphocytosis, what I was just wondering was, would it also apply to benefit with mycophenolate, or is the evidence only in favor of giving steroids?
Well, steroids is what people have given, but we've no reason to think that you get a different answer from mycophenolate. And at her age, I would be wanting to limit the steroids.
Sure. Prahlad?
So I think we shouldn't be saying it's got to be one diagnosis or the other. You're allowed to have this combination.
Yeah, and I guess fibrotic HP seems to, so it's overlap, fibrotic HP, CTD overlap, which we have seen a few. We've seen CTD ILD with a fibrotic HP pattern. But now this is fibrotic HP dominantly with some CTD overlap, right? Prahlad, do you see this often?
Because the hypersensitive pneumonia is so common and
Right.
CTD ILD also extremely common. So we see sometimes this overlap. Yeah, I agree with you. I think bronchoalveolar lavage make me a little more comfortable in putting her on mycophenolate.
Immunosuppression.
Immunosuppression.
Yeah.
I think there are also a couple of interesting points there, Sujit. The fact that it's worse when she's Bikaner, and we know that Rajasthan has a lot of pigeon exposure. So that's an additional little bit of evidence.
Correct. Yes. So that's great. I think I got the answers there, and we learned a lot about genetic testing and genetic counseling, Athol, when Sonia and Erin were in India. And we realized we are doing very little counseling, which we need to do better than what we were doing. So, with her.
I like that statement. Initially, we used to send the patients for genetics test, and later on nowadays we send the patient to interpret the genetic test.
It's no, this it's been a fascinating week last week and a lovely MDD. Asmita, where are you? You
Well, I'm
said
going to have to dash away now.
we can't hear you, Asmita. Your audio has gone off. But anyway, if she's having problems with her audio, then I will close the MDD. It was a great.
Can you hear now?
Now it's better.
Yeah.
That's right.
So I was just saying that it was so great, 6 interesting cases, and yes, sir, you can close. We will have next on 31st October.
Yes, 31st October. Thank you, Athol.
And can we have 6 cases, sir? There are so many now itself. I have
Today
so
we
many
went. Are we offline? Are we offline, Asmita?
No, I am not sure.
Tech support. Tech
Arvind,
support.
can we make it offline? Thank you so much for those.